Hi, I'm Jim Sheehy, and there's been a tremendous amount of interest shown in the last 5 or 6 years in regard to the matter of treatment of tinnitus. And we have with us today, I'm happy to say, two people who have done a great deal of talking about various aspects of tinnitus throughout this country and the world. Um, to my immediate right, I'm happy to say we got Dr. Jack A. Vernon from the University of Oregon to come down here to join us. Jack is a PhD. He received this in 1952 from the University of Virginia. And in psychology, most of you think of him in terms of being in audiology, but he is PhD in psychology, and then he spent 13 years with Glenn Weaver at Princeton, and then 13 years ago joined the University of Oregon Medical School, where he is professor of otolaryngology and the director of the Kresge Hearing Research Laboratory. To Dr. Vernon's right, on the end there, is my associate, Dr. John House, from the Otologic Medical Group. John practices otology with us. John is also in charge of the tinnitus program at the Ear Research Institute and has talked many places throughout this country in regard to biofeedback training in connection with tinnitus. To my left is Dr. Ed Johnson. Ed is also a PhD in audiology. He has been at the Otologic Medical Group longer than I have.
He's 25 years.
25 years. And he is the director of our Department of Audiology and a consultant at the Ear Research Institute. You know, I thought it might be worthwhile to begin by showing you a little bit how Dr. John House and I and our associates in the Otologic Medical Group discuss tinnitus with patients. We have a number of patient discussion booklets. This one happens to be on the subject of tinnitus and head noise. And I might mention in passing that these booklets are available through the Ear Research Institute without our names in them anywhere, so that you can actually buy them from them. We've got books on tinnitus and dizziness and chronic ear disease, and I think about 7 or 8 of these, so those of you who are interested might wish to explore that. But these booklets are for patient discussion, discusses the hearing mechanism, objective tinnitus, muscular, vascular, external ear tinnitus, brain tinnitus, and so forth. And then it gets into the matter of the treatment of tinnitus. Let me tell you a little bit just how, let's assume that we have a man, he's 65 years old, he has a little bit of presbycusis, and he's got tinnitus, and he's sitting in the office. Let me tell you a little bit about how I explain this to him. Using the diagram that's in the front of this booklet, I identify the fact that he has an impairment in the hearing nerve, and in regard to the tinnitus, that the little hearing nerve fibers that have deteriorated some with age are sending out false electrical impulses to the brain, and that anything that comes in on that nerve, the brain interprets as sound, may interpret it as crickets, as ringing, as buzzing, and we don't know all we'd like to know about that for sure. Now, I tell the patient, fortunately, the symptom you have, this head noise, is not serious, it should not be progressive, and in almost all cases, it diminishes with time. Now, it diminishes with time, many times goes away, primarily when you learn to ignore it. Pay as little attention to it as possible, because the more you think about it, the more you notice it, the more you notice it, the more you think about it, and it becomes a vicious circle. Then I would get into the matter, perhaps, of the biofeedback and tinnitus masking, but we're getting ahead of things there, and we'll get into that in a short while. You know, Jack, a question that I certainly don't know the answer to, and I was talking to you about this before we started, is just what do you think causes tinnitus? Now, let me preface this by saying that you know, back when Dandy was doing his nerve sections for Meniere's, we had a peripheral disease in the labyrinth, Meniere's, and the patient would have tinnitus, and you'd go in and section the nerve, and the tinnitus would continue just exactly the way it was. We noticed the same thing in acoustic tumors, I believe. What is your feeling as to what actually tinnitus is?
Well, you want to take that particular case?
No,
for
just
example?
take in general.
All
What
right.
is your feeling as to what tinnitus is,
Well,
and
first,
how it develops?
Yeah, let me back up to something you said earlier, which I find that you and I use very much the same kind of approach with patients. And let's just take the case that maybe it is a peripheral signal, an aberrant signal or a false signal that is going up into the brain and being perceived as such. One has to wonder how on earth can that signal continue when that part of the ear has, let's say, been wiped out by acoustic trauma. And yet we know that acoustic trauma does induce tinnitus. It may be one of the most easy ways to get this phenomenon. So if the original insult has all healed over, now not recovered, in the sense of getting new hair cells or anything, but has all healed over and the damage insult is gone, why is it that the person still hears this? And I don't know the answer to that, Jim, but let me make some guesses. One finds some very exciting work going back to about 1935 with an anatomist named Livingston who wrote a book on pain mechanisms. And he addressed precisely the same problem in the phantom limb problem and in intractable pains. And his hunch, and one can build some evidence for this, his hunch was that you really did set up circuitry within that area that the brain is devoted to reception of incoming auditory messages, and that circuitry became self-perpetuating. And you had literally
a vicious circle of
an arc, that was ongoing there. And he would then look for ways in which to interrupt that and break it. Now, that's an attractive way to think. Indeed, we can think about the efferent system that's doing a feedback loop for us and helping with that in the ear. But let's take the case that maybe the opposite is occurring. And it seems to me this is a reasonable hypothesis. Let's just look at one little fiber in that cable that's coming out of the ear that is our eighth nerve. Now, there's something like 60,000 fibers in there, and they're unique. There's no other nerve bundle in the body like this bundle. Every fiber in it is practically uniform size. It's not a mixed bundle. And every one of them is very, very noisy. Now that seems ridiculous. The thing you'd want to enhance, it seems to me, if you and I were designing the system, would be a signal to noise ratio. You'd like for the signal to be very big and the noise to be very low. But in the auditory nerve, the noise level is very high. That nerve is chattering all the time. Now let's take a very simple-minded, feeble-minded view of this. This is a view that I'm very comfortable with, Jim.
Okay.
And let's say that we've got a scanner or a receptor up here, or somebody up here who is looking at the input from the auditory system. And it sees this chatter, this noise that's going on, and it says...
By noise, you mean a continual electrical output from the ear.
Even in the absence of any input of sound. And it's the receptor, the sensor up here says, in effect, pay no attention to that. That's just the nerve keeping itself tuned up. That is not a signal. That's of no consequence. And then now comes a signal. And that is something that, let's say, is, if nothing else, in magnitude different than the noise. And so the sensorium says, that's a signal, pay attention to it, what is it? Now it seems to me that if you have had this noise chatter going on and then you shut it down, as with the disappearance of those nerve endings or those fibers, that the scanner says, that's a signal, that's different. That's not the usual chatter we see here. That's a signal. That's highly speculative, Jim, but it seems to me...
It's an interesting theory, and certainly it seems to make a bit of sense.
Certainly not original with me, but I think it does make some sense.
Well, of course, it makes some sense, too, particularly if you're thinking in terms of the way biofeedback might fit into the matter of treatment of tinnitus. And, John, I know that you made a seminar on the subject, 2 or 3 years ago with your lovely wife, who is also a PhD and very much involved in this. I wonder if you'd like to say a few words as to where you stand on overall picture of biofeedback in the treatment of tinnitus at this point. And I must say, there's a cartoon I received once, and I saw in the paper. It was a cartoon, and this woman was sitting in front of a doctor, and he had all these diplomas on his floor, and she was saying, you mean to say with all those diplomas, and you can't do anything for my tinnitus? Well, I think that's one of the messages we're trying to get across today, that there are things to be done. John, could you let me know a little bit about what the overall feeling is on biofeedback and tinnitus right now?
Yes, Jim, we're still rather enthusiastic. We continue to treat patients with biofeedback. As we talked about in our seminar that Jim alluded to a couple of years ago, we did demonstrate exactly how we did the biofeedback, and I think it would be good at this point for me just to tell you a little bit about that and how the biofeedback works so that we know what we're referring to. On the tape that we made 4 years ago, we did have a segment of biofeedback, and this patient has the sensors attached around her masseter muscles because in her particular case, she was a patient who liked to clench her teeth a lot. And it's not unusual, Jim, to see patients who will come in and say that when they clench their teeth, their tone in their ear changes. It gets louder or it changes pitch. And we have found by using the biofeedback, in other words, by feeding back the information from the muscle activity, we could teach the patient to learn to relax those muscles. And in so doing, when they learn to relax these muscles, this seems to change the quality and the quantity of the sound which they are getting from the ear or from the brain, which they're, of course, interpreting as tinnitus. We've also found that it's important to use the sensor on the finger to measure the skin temperature, because a patient can learn to dilate the blood vessels in their peripheral circulation. And this, again, seems to be the most effective, is the patient who can learn to relax the muscles and to open the blood vessels and increase the temperature. And interestingly, we have found that patients who cannot do one or the other do not respond well to biofeedback. They may do one very well, but not be able to raise the temperature of their finger. So in answer to your question, we still are, in fact, using biofeedback and finding it to be very effective in the group of patients who are willing to stick with it. Now, the difference between biofeedback and maybe a tinnitus masker or an operation or a medication is that it does require the patient to actively participate in the treatment.
You know, John, I'm going to, a little bit later on, I'm going to ask you to clarify just what type of patients seem to do the best with this. That's a very interesting tape, and for those of you who haven't seen the full tape, that segment of which he just showed, why, I think you'd find it most interesting. It's a fascinating thing. The problem is the patients have to stick with it, and it takes time, and this is a problem, because a lot of patients, you really find out who does and doesn't have the problem this way, because if they've got the problem, they'll stick with it. Jack, you have become internationally known in regard to tinnitus masking, and I know from what I hear from some of our visitors and from some of our conversations during the last 24 hours that you've been traveling all over the world on this tinnitus masker thing. You know, it's interesting, for years and years, otologists have known that, you know, you turn a little hi-fi on in the room when you're reading and that masks out the tinnitus. You don't hear it. Or you have a little clock radio or a fan or a little buzzer that goes on in your bedroom when you're trying to go to sleep, then you don't hear the tinnitus. How did you get into really developing this, really defining this thing? What was in back of the development, the principles involved with the tinnitus masker?
Well, like most things, accident, Jim. And it's, if I may just tell the story, we had been working on the problem of tinnitus and trying to develop an animal model, and for no other reason except that as a laboratory and a clinical department, it was incumbent upon us to attack this problem that was so prevalent, so ubiquitous. And so we were trying to develop a system where rhesus monkeys would tell us when they had tinnitus. Now, out of a set of accidents, and I won't go into the details, but out of a set of accidents, a man from down here, from Downey, California, came to see us because he had been told that we were the only people in the country researching at that time.
Was that the one you told me was one of our patients?
Yes.
Yeah,
yes,
one of our patients.
Yes. Absolutely delightful man named Dr. Charles Eunice.
Said many nice things about us, I'm sure.
Oh, yes.
Okay,
absolutely.
good. Fine.
Absolutely. And, but Chuck came to see us, and I hadn't the faintest idea what to do with this person, except that I had a very gnawing thought in the back of my head that said, here's an animal that can tell me about tinnitus. Why I don't have to train him. He can respond and we can interact. And that's when I first got the idea we ought to be working on humans rather than other primates. And that day that he was with us, we went to lunch.
How long ago was this, Jack?
This was about 5 years ago, 5.5 years ago. That day we went to lunch, and as we often do in Portland when it's a nice day, we get sandwiches and go out to one of the many fountains in the town, of which there are many and they're lovely.
This is what you call a commercial for Portland.
That's right.
Okay,
That's
good.
right. And as we walked up to this fountain, it had a series of steps. We sat down on some steps, and Chuck just kept going. And he walked up, and I thought ostensibly to look at the fountain. But he stood there so long that finally I went up to him and I said, "Chuck, are you all right?" And he said, "Shh." I can't hear my tinnitus here because of that water sound. And that, for me, was when I got the idea of masking. Now, obviously, we couldn't plant Chuck by that waterfall the rest of his life, but we could put some sound in his ear that would be like it. Now, I must say that everything that happened after that really proved how difficult it was rather than how easy it was. But that's the accident on which the whole thing started.
Were you immediately able, were you in a position where you could just start out on the project? Were you immediately able to get funding for it, or
no,
what?
No.
How did you get,
Oh, no.
if you can
Gosh,
answer me
no.
in a minute, how did you get the money to get involved in what must have been a rather
Well,
expensive project?
We did not get the money, as a matter of fact. It was much later before we got any funding at all. And what I did was to go to one after another hearing aid manufacturer and say, "Will you make for me a device that'll put waterfall in a patient's ear?" And they said, "No way." And I said, "Why? This is going to work." And they said, "No, it won't work, and it's a dumb idea, and we won't touch it." And then finally, one man who was a friend, but also a president of a hearing aid company, said, "Okay, I know it won't work, but I'll make some for you anyway. But it's just because you're a friend, no other reason." And that's how we got it going.
You know, one of the fascinating things here, and some of you may know this, but I want to point it out so that you've got the clear picture. Here we have a PhD psychologist who is a researcher, but he is working with clinical patients. And this is unusual. Many times there's a tendency to stick in the research thing. And Jack Vernon not only is now become known more as an audiologist, which he's really not, but he is, but that wasn't his background training, but he's also trying to work on problems that the clinician has rather than research laboratory problems. And that's why we're all so pleased to have you going around talking around the country and around the world. You know, when we've got, I'd like to get into a little bit about the patient management now. We've talked about what we say, we've talked about some background information. It's been one of my impressions that by far the best tinnitus masker we have, the best way to treat the problem, realizing we can't cure it, is to get a hearing aid on the patient. If the patient has a hearing loss, this is the impression I've gotten from Ed, from you and your staff and our discussions at the Otologic Medical Group, that in fact, if the patient has a hearing impairment and will wear an aid, that's probably going to do a great deal to resolve the matter. Could you tell us a little bit about your experience with this?
Yes, I'd be glad to. We feel that if the patient has tinnitus and a hearing loss, the first step should be to try to alleviate the hearing problem. And then if we can cover the tinnitus by the sound of amplification sound into the ear, we can achieve two things at the same time. We can improve communication and we can lessen the impact of tinnitus. Now, I've brought along a couple of cases that I thought would be easy to illustrate.
Can you show us the audiograms?
Yes, let's put that on. I'm talking about a patient that has hearing that is within serviceable limits on both ears, speech reception thresholds of 30 dB. And if you look at his discrimination score through earphone, 100% on his right ear, 92% on his left ear, that patient is really, you'd say, functioning pretty well. Unless, yes.
Excuse me. Did this patient come in for tinnitus or for hearing problems?
This patient came in because he was bothered extremely by tinnitus. And
that's one area where we don't agree completely, is on the pronunciation of the name. And I tried to convert him last night, and he tried to convert me this morning, and so we'll let it stand.
Okay. Well, I think the interesting thing about this patient is that if you look at what happens when you test him sound field, even in quiet, at a soft conversational level, he's getting only 68% of the PB words. And then if you put in a competing noise tape, it's only about 50%.
I think it's fascinating, Ed, that the patient brings himself in for tinnitus.
Yeah.
The family or friends bring the patient in for hearing
For
loss.
hearing loss, that's right.
You're a leg up when the patient brings
And
himself in.
fortunately, this is one of the
Yeah.
cases where by putting the aid, the severe tinnitus was in the left ear at around 2,500 hertz, and it was a steady ringing tone type of tinnitus. And putting the aid on completely covered up the tinnitus as long as he wore the hearing
Did you
aid.
fit him binaurally or just
Oh,
on his
yes.
left ear?
No, on a
Binaural.
case like this, we would always go binaural.
Yes.
Matter of fact, most patients, we try to get aids on both ears if we possibly
What type
can.
of ear mold?
Oh, we used a fairly open ear mold
Open
in
ear mold,
this
open tube
situation.
type?
Yes, we had open
Yeah.
tubes on this
Binaural
patient,
fitting,
binaural
right.
fitting, right. And so we were able here to achieve the two objectives of improving hearing and covering the
Masking the
tinnitus,
tinnitus.
right. Now, the second case I think might be interesting because this patient, you see, has a kind of hearing loss that even 3-4 years ago we would not have put a hearing aid on. And yet we're now fitting many, many people with this kind of configuration.
Let me ask you, for my information here, the fact, if the hearing were up at 3 kilohertz, you probably wouldn't have been able to go to an aid. The fact that it was down at that point, is that significant?
Oh, it certainly is, and a little bit of a drop at 3,000, a steeper drop beyond
Yeah.
that enabled
But
us to.
3,000 is relatively critical in terms of whether you think you can use an aid.
Yes,
for
it
hearing.
is.
Yeah, okay.
But very close to normal at 2,000.
Yeah.
Certainly on one ear,
Yes.
absolutely normal
Yeah.
at 2,000.
That's right. He has a threshold of 5 dB on the left and 15 on the right.
I'll ask the question here, did that patient come in because of hearing or tinnitus?
That patient also
Or
came in
tinnitus.
because of tinnitus.
Okay, came in
And,
because of tinnitus.
Interestingly enough, the tinnitus was in the better left ear. Again, a fairly high frequency sound. Again, an incessant, steady ringing sound. And again, we were able to help him. We could cover up the tinnitus with the hearing aid and give him this discrimination help. As a matter of fact, when we tested this patient in quiet at a 55 dB sensation level, he understood only 64% of the words in noise, and yet we could bring that up to better than 80% with the aids.
Was this patient in some kind of noisy environment or had military experience, or what was the
there
noise exposure?
There was no history of noise exposure
None at all.
But
it
it
looks
looks
it
like
looks like
noise.
it looks
Yeah,
like
it looks like
yeah.
noise.
But it was unilateral tinnitus?
The unilateral, left ear only. Now, the next case, we'll cover this quickly.
John, you
I
had
was gonna
a
say,
comment.
you fit him with binaural aids.
Oh,
so-
yes, indeed.
Yeah.
We'll
And
always
he,
go.
He got help from his hearing with this, particularly in difficult listening, right?
In
Yeah.
noise situations, it helped the hearing
Yeah.
and it covered the
I think
tinnitus.
this one I've seen before. This is one of my
Well,
favorites.
yeah.
If this is that lady, is it?
This is one of
Oh,
my
yeah.
favorites,
Oh,
too.
this is great.
Because this patient does have a significant hearing loss, and you would think that she would present herself because of her problems of hearing. And yet she came in, her overall complaint was noise, head noise. As a matter of fact, she didn't want anything to do with hearing aids. And when she came back to see me and I told her we're going to try to work with hearing aids, she said, no way. I just want somebody to take away this head noise and I'll hear all right. But
Isn't that interesting how many
It really
times they
is.
say that?
after working with her a little bit, and I said, well, just let me slip an aid on that left ear because that's the ear again that was bothering, the left ear. And we put an instrument on and she looked up and she said, my goodness, I don't hear this noise. And I said, well, that's marvelous. We went ahead, I worked with her. I wanted to work with both ears. She wouldn't let me touch her right ear. Just the left ear, she just wanted to take care of the noise.
And then
see?
she's the one that phones you in.
2 weeks
Yeah, 2
later,
weeks
she
later.
called in and she was very happy at that
Let's go
point.
with the right.
She said, this is a whole new life for me. I'm just delighted with this. But a couple months after that, she called in and she said, Dr. Johnson, I'm terribly distressed. She says, something terrible has happened. I said, I'm so sorry. What is it? And she said, well, the noise now is so bad in my ear. And I said, you mean your left ear, the hearing aid no longer covers that left ear? She said, oh, no. She said, it's the right ear.
Yes.
And it's much worse than the left ear ever was.
Yes, yes.
And so, needless to say, we got her back in, and at this point, she was willing to go and do an aid on the left side also.
What age lady is this?
She was about 68.
That's very interesting. I had a lady the other day that we could cover up with a hearing aid, and she refused to wear it. I asked her why. She said because it'd make her look old. She was 66. I said, you are old. You're 66. What are you thinking about?
It's like asking a 66-year-old to use a cane. If I asked you to use a cane, you'd use it.
You
If
bet.
I ask a
You bet.
66-year-old, they'll say, absolutely not. No way. Because it's a thing.
Just as a quick summary,
Yeah.
the whole message here that I'm trying to get across, I guess, is that if we do have a patient with hearing impairment and tinnitus, and if we can control the tinnitus in this manner, this is the way we'd like to go. And about half of the patients that we've worked with, this has been successful. The other half, it has not.
Well, yeah, let me
just bring up one thing, Jim, because I think you've done some work on this. We talk about patients with sensory neural hearing loss with tinnitus. Now, Jim, you've seen a lot of patients with otosclerosis and tinnitus,
Conductive
and then you've
losses.
operated on there and corrected their conductive component. What has your experience been
Well,
in regard
the
to
interesting
tinnitus?
thing, I know from in reviewing a large number of my own cases of stapedectomy, that if you take those that get a good result, which is about 95%, and then those that had tinnitus, I find that 50% lose their tinnitus, 25% say it's better, and about 24% say it's exactly the same, and 1% says it's much worse, which essentially says you can't tell one thing what's going to happen. That brings up the old matter of putting noise. If they can hear more outside noise, it should mask it out, but that ain't the case.
Not always.
That is not the
No.
case here in at least 50%. Well, you know, what I wanted to ask you a question, Ed. I'm sure that, let's take this last patient you had. Now, supposing she did not, as you helped her hearing, but her tinnitus was still just dry. She couldn't sleep. She couldn't do anything. Do you ever refer these? I know you work with maskers at times, so you might have gone into this, but let's say, do you ever take and refer a patient for biofeedback treatment?
Well, if it's unsuccessful with the hearing aid, and we probably have tried a masker and it isn't helping, and then certainly we do want to try to get some help in biofeedback. But what I do is simply refer her over to John, because he's our expert in this area, and he will tell the patient what's involved.
Well, let me ask you in connection with it, John, would you also clarify what type of patient seems to do the best with biofeedback training?
Well, Jim, what we found out, and this was interesting to me, I got into the whole area of tinnitus when I first came to the office in 1975. And at that time, I began to work with tinnitus patients doing transtympanic electrical stimulation. We discussed that earlier, and to find out whether that would have any benefit on getting rid of the tinnitus.
Because some of our implant patients lost their tinnitus.
Exactly. So
Yeah.
we thought maybe we could stimulate them electrically in the office. Well, unfortunately, we did not help their tinnitus with this particular treatment, but it gave me some idea as to what was going on. I was very impressed with how really upset patients do get with their tinnitus. And someone had mentioned that maybe biofeedback would help. So we took a small group of patients and we put them through a rather controlled study on whether we could give them a given number of courses of biofeedback. And much to my surprise, about 3 out of 4 reported significant improvements in their tinnitus. And these were patients that were rather, had tried everything else and were totally unsuccessful. But the thing that we
This
did...
was before the tinnitus masker, though, wasn't it?
Well, this is about in 75, yeah.
That's
Just about the same time that he was beginning to do his work, we were beginning to do ours.
Yeah, what I mean is they hadn't been tried with that.
Oh, no, we didn't have that.
Right.
That's correct. Certainly they had tried hearing aids, and several had surgery for conductive hearing losses and so on. But we did do...
Yes.
We did do psychological studies on these patients, and this is when we found out that the ones that were successful in their biofeedback training, first of all, we found that all of the patients that went through the study did have abnormal psychological profiles. They tended to focus on their problem. They tended to be a little bit hypochondriacal. They also had some psychosomatic complaints, other psychosomatic complaints. And what impressed me is a great deal of them showed a significant amount of depression. And this impressed me because one of the old treatments, of course, is you put the patient on Valium or you put them on Librium when they have tinnitus, well, which is actually, in fact, will cause further depression.
Yeah, that's not what you want to use in a depressed
Well,
patient.
exactly. You want to use something like an antidepressant. So we found out that the patient then who would respond well to biofeedback is the patient who is not sleeping well at night. Let's say he goes to sleep well, he wakes up in the middle of the night, can't get back to sleep. It's affecting his ability to concentrate. He's not doing well on his job because of he says it's because of his tinnitus, because it really does cause a great deal of distraction. We did take patients, interesting enough, who have had the group of patients, which are most of our patients. You tell them what the problem is, and that's fine. They're satisfied. When we took that group of patients, we measured their tinnitus, we measured the patients' tinnitus who have severe tinnitus, and we found out the relative loudness on our tests comes out the same. We also did psychological profiles on a group of patients who had tinnitus and said it didn't bother them, and we did psychological profiles on patients who had tinnitus and it did bother them. And we did find out that all of the patients who the tinnitus did not bother were perfectly normal on all of their psychological profiles. So there definitely does seem to be some correlation between agitation, depression, anxiety, some over concern about this problem.
Excuse me, John, do you have the feeling that if you have taken care of the tinnitus, that then they get converted into some other problem? And
I've had that.
Hypochondriasis comes out somewhere else?
Oh yeah, I've had that experience
Have
on several of my patients, but that's one thing where the biofeedback has been helpful, though. It has helped the patient to become more aware of how things are affecting them. And even though they may develop temporomandibular joint pain after the ringing goes away, or they may develop headaches, at least they learned enough insight into realizing that they can now control these things by using the biofeedback, by using the exercises we give them. And patients, years, now it's been 4 years, 5 years since we started this project, and patients are still using the exercises, they're still listening to the tapes.
How long does it take them to learn it? As I understand, you have about 12 sessions.
About 10
And
to 12
you don't
sessions.
do this personally, do you?
No, I don't.
12 sessions, and then you've taught them how they can sort of, I use the term, I guess incorrectly, hypnotize themselves at home, but I look upon it almost like a form of meditation or self-hypnosis.
Oh, it really isn't. It's actually learning to control, learning to exert conscious control. Now, hypnosis implies subconscious control.
Right.
We're talking about conscious control over areas of their body that they did not previously know that they could control.
Well, listen, Ed, I'd like to get into the tinnitus masker thing. When I see a patient, going back, I told you I was talking to my patient. Now, if my patient is having a terrible problem with tinnitus, you know, I can't sleep, it's bothering me, I'm going to lose my job, it's interfering with my relationships with my family, I try to identify, and if they look like they are depressed or extremely, you know, one of these active, very high-pressure individuals that don't want anything to bother them, I will oftentimes suggest that they get involved in biofeedback therapy if they don't have any hearing impairment, or I'd go the other route first. But Ed, if they're not, if it doesn't appear to me that they fit this profile, and it's not always possible to tell,
Right.
but if it's not possible, I'll often send them back to you and Weldon Selders in our audiology department for a tinnitus masker evaluation. What do you do at this point?
Well, we have a set routine that we follow for tinnitus evaluation. But you know, I learned our routine from Jack Vernon. We went up to Oregon a couple of years ago and sat in on one of his workshops in San Diego. And incidentally, Jack gives these workshops along with his colleagues in Portland all around the country. So
And now in Europe too, I understand, right?
Wherever you are, you can take advantage of learning from the expert on this. So the question really should be answered by Jack.
Okay, I'll put the question to you, Jack. What
It's a
I'm
dirty
interested in
trick.
hearing, what I'm interested, I think, just briefly, and without necessarily going into a tremendous detail, how do you go about selection and fitting? And there must be a sorting out process that you get involved with.
Yes, there is. But may I ask John a question first?
Sure.
I was very interested in your comment, I think I understood it correctly, that if you could cause the patient to adjust tension here as well as control fingertip temperature, that was a much better candidate than if they could do one alone but not both.
That's right.
Good.
Well,
Comment a little on that, if you don't mind.
well, what we're
Because we
talking
use
about
biofeedback
Right.
too, as you know,
Okay.
and I'm interested.
no, what we found is that with a patient who does one but not the other, it doesn't matter which one it is, if they can't learn to do both of them, their results are not as good. Now, I think that there's every patient who has a tension in their muscles of their neck, their masseter muscles or their frontalis muscle will complain of the tinnitus, and particularly the tinnitus will get worse when they're either fatigued or they're tense, and they become aware of this. Now, if they can learn to relax those muscles, that has an immediate effect on their tinnitus. But for some reason, and we don't really understand why, if they can learn to increase their peripheral circulation by learning to, again, relax their peripheral blood vessels, then that will help their tinnitus. And unfortunately, we know people who do biofeedback and they only use maybe one modality, and we find out that their results are not as good.
You know what Jim?
I'm going to have to send him a copy of your seminar because otherwise it's going to turn into a biofeedback
I do
seminar.
want to see it.
Well, I'll send you a copy
but
of
I
it.
can see Jim now. He's going to have you treating these patients with niacin first, and then just teaching muscle movement here, and
Well,
he'll say you affect the.
All right, I want to go back to the question. I asked you, now, if you don't answer the question this time, and briefly, I'll tell you, I will let you in. We've already decided as soon as we get through with this little roundtable discussion, I'm going to turn this over to Jack for a whole hour, and he's going to do a tape on the details of this. But what we want to know is, give me the basic outline as to how you go about selecting them, fitting them, testing them.
Okay.
And if you don't answer the question this time and refer to something else, I'm going to assume you're going to try to keep secrets. That's not ethical.
The first thing, the absolute first thing, and I think it's mandatory for everybody working in this area, is to see that that patient has had a full ENT otologic examination. Now that, it seems to me, is critical. You just may not take the chance of covering up an eighth nerve tumor or even covering up anything else that can be medically corrected, because obviously that's the proper way to go first. So that's the first screening. So the patients who come to us now are the ones for whom medical treatment did not seem indicated. The first thing we do then is to do an audiometric assessment on these people that is fairly simple. That is, it's hearing thresholds, speech discrimination, that sort of thing, and then tinnitus testing. And quite briefly, the only thing we are looking for there is identification of the tinnitus. That is, where is its primary pitch, and what is its loudness? And John, you made a very important point that I think is one of the reasons that this area has been avoided for so long. That is that when you do measure the loudness, subjectively, it's not loud. 5, 6, 10 dB, sensation level, and that's it. Now, if you go back to Fowler's work in the early 40s, he was saying, if you do that, then you have a basis on which to say to the patient, you really don't have a problem. It isn't that loud. But it's not loudness that has to do with severity.
Right, it's the psychological things that John was talking about.
Absolutely,
Yeah.
and the constancy of it. And maybe one other thing that I'm trying to get a handle on these days, and that is not only how loud is it, but now, using that same sound as nearly as you can, how far do you have to go before you mask it out? Now, if the sensation level for masking is 10 dB or less, then you've got an excellent chance of affecting a substitute. But when you start going up 20 and 30 and 40 dB, now we're talking about a tinnitus that cannot be masked, and it's not even appropriate to think about masking. I was testing a diabetic patient yesterday. I went 60 dB sensation level and didn't touch his tinnitus.
Even though you'd identified the exact area of the tinnitus,
Yes.
and you went 60 decibel above the...
And did it ipsilaterally, bilaterally, every way you could think of, and could not touch that tinnitus. Now that is clearly not somebody you're even going to think about putting masking on. So that's what I look for, Jim, the inappropriate cases. Now everything that's left over, we try masking on. And very much like Ed, the first thing that I insist on is, if a hearing aid will do it, for heaven's sakes, let's do it that way. Just the other day, Ed, we put a pair of hearing aids on a guy, and he was going to say, my tinnitus went away just like that. And he said, good heavens, I didn't know I could still do that. And it was the first time he'd heard his finger snap in a long time. I could not agree more with what you have said.
Let me ask you, in connection with this, in your own setup, realizing that you could possibly be seeing a selected group of patients to a certain extent.
Oh, yes.
But in the general run of things in the Department of Otolaryngology, do they, in other words, the patients that you see are the ones who are bugged by their tinnitus. They don't send a lot of other problems to you. Normally, you only see those who are really bugged by it. Would they be likely to get involved in biofeedback first if they fit into a pattern where you thought that would be helpful, or would you go first to the tinnitus masker?
No, we would go to the masker first, or the hearing aid, or the combination first, but only because we don't have any competence. Now, I have great confidence in
confidence,
biofeedback.
but not you don't
We
have,
don't have
you
any
don't have the
confidence.
setup. Yeah.
And we do have a lady downtown, and I want to talk to you about her later, but we've been sending patients to her to get biofeedback because I'm convinced that I don't really care where the tension came and caused the tinnitus or the tinnitus caused the tension. You've got to get rid of that tension.
Well, can you make a comment in regard to your experience with those patients that I might normally refer to biofeedback first, that they've got fairly normal hearing, they don't need an aid, they're just driven to distraction by their noise, and they're depressed. I may have tried some Elavil or Triavil with them first, or I sometimes will try some Dilantin to see what goes on. But then I've referred them to biofeedback. Now, in your institution, they might come to tinnitus masking first. What is your experience with tinnitus maskers on patients who are depressed?
Well,
Or have you come
Oh,
to any
no,
conclusion?
we
Because this is
have-
the one that John's likely to help the
yeah,
most.
there's no question we have seen very depressed patients. And actually, I, in all honesty, think we do a disservice when we try masking that does not work, they become more depressed.
More depressed.
When we
It's
try
like a treatment that isn't effective because that reflects on the person who prescribed the treatment.
well, it's
too.
then their hope is kind of washed out on them. And
You find we're talking a little bit about this vicious cycle, where the tinnitus is causing them not to sleep well, it's causing them to be depressed, or the depression is causing the tinnitus to get worse, and we don't know which came first or which is aggravating the situation more. But do you find, like, for example, if you do put the mask on and it does work, so the patient's outlook gets better, they do begin to sleep better at night and things
I
like that?
think so, John. But I also have not done the psychological testing that you have. And I have so many cases, though, where the spouse has called in or come in and said, thank you for giving me back my husband or my wife. Things are back to normal now, and we're living a reasonable life, and things are vastly improved.
There's one thing that hasn't been touched on here, and I think I know John has some thoughts on it, and maybe you have some too, and that is the use of various drugs. I mentioned he mentioned depression. I mentioned Triavil, and I mentioned Dilantin. There are some of the things that have recently been recommended, lidocaine, and then there's mersaline or something like. Could maybe the two of you tell us a little bit? Jack, what is your thought on some of these newer drugs that have been advised for tinnitus?
Well, Jim, what I really think is happening there is that people are beginning to look for cures of tinnitus. And I see up to now, I think everything we've been talking about is relief of tinnitus, palliative measures that are effective. And I hope we've convinced you that there are things you can do for many, many patients. But now, fortunately, there's an effort afoot that started actually in New Zealand with Pamela Melding and that group, Good and Thorne. And they found accidentally that injections of IV lidocaine had a temporary recession of the tinnitus. And I don't know how John feels about this or any of you, but I'm very impressed with that work. It says to me that even though that recession, in a very small study done in our group, 9 out of 11 intractable patients, we could do nothing with masking on them. 9 of those patients had total loss of tinnitus during an IV lidocaine injection.
Is lidocaine the same as xylocaine?
Yes.
Yeah.
And in England, it's lignocaine.
Yeah.
But that whole family of drugs, I think, has to be studied. I don't follow the next step where they decided that because that used to be used as an anticonvulsant, then you put the patient on anticonvulsant drugs like mycilline or Tegretol. That worries me because they're very dangerous drugs.
Well, John, isn't there something that recently John Shea and his associates talked about? I think it's sort of like lidocaine that you take by mouth.
Right, it's an
Yes.
oral
Yes.
lidocaine type. It's tokenide, and it's taken orally, a relatively long-acting, 6 or 8 hours. And the idea, of course, if the xylocaine works IV, maybe taking it orally will also work. There's obviously no data at this point that we could really hang our hat on and say that it's going to work, but it certainly is exciting that maybe sometime in the future something like that would work.
Do you think there's a chance enough of that will be absorbed through the gut to get there and get the blood levels up before it gets metabolized?
Apparently it is, because it's actually used for cardiac arrhythmias.
Yes.
That's what the original
Yeah,
was
I
developed
might
for.
comment. I've had no experience personally with this material by mouth. What's it called?
Tokenide.
Tokenide. But I was talking down in Birmingham about a month ago, 3 weeks ago, and was talking to a couple of doctors who had gotten some of it, and they said that in those where they could relieve it with the IV, they were most impressed with it over a period of 2 or 3 months. And they were so enthused, they wondered what we had done with it. I said, we haven't used it, and they were just amazed.
We can't
But they
get
were
a hold
very
of it.
enthused about it.
It's not really out for
That's right.
general consumption, and I'm trying to get it. We'll be probably doing a project on it when the company decides to try it.
Well, let me, at this point, I think we're getting to the point where we're going to wind this up a bit. I wonder, Ed, let me start with Ed Johnson and ask you, are there any, in the next few minutes, any points that you'd like to make, or the questions that you think have gone unanswered or something?
Well, I think there are a couple of points that we should cover that we haven't talked about. That is, first of all, that if the hearing aid will work fine, and it does in a certain number of cases, but we can't expect any residual inhibition through a hearing aid, which we will sometimes get through a masking device. In other words, when the patient takes the aid off, then the tinnitus is back up again. But if, so that's one thing. Let's see, I had another thought in mind and it has escaped me. We'll come back
Well,
if I
let's
pick
just
it up
deal with
here.
that one. I know I've heard Jack talk about residual inhibition a great deal, and you're going to go into it a lot in our other seminar here a little bit later today. Do you have a comment on that, though, at this point? That
I
would
think
be
so.
worthwhile?
One can't help but make guesses on why is that,
What is residual inhibition? What do you mean by that?
Well, in this case, it's a purely descriptive phenomenon. I'm just talking about the absence or severe reduction of the tinnitus after a period of masking, when the masking, in fact, has been removed. And that does not ever occur with a hearing aid. That is, you could have complete masking of the tinnitus with the hearing aid, but the moment you take the hearing aid off, the tinnitus is right back. And I take it that's your experience,
That's
too.
right.
Yeah. But it seems to me that what's happening there is that in the hearing aid you don't have quite as selective amplification of the specific sounds that are accustomed to the tinnitus, but rather a broader spectrum of sound.
Thank you, Jack, because now it cued in what I wanted to say before, the fact that now we have instrumentation that will give us hearing help and a masker in the same device.
Yes.
So that if the hearing aid doesn't do it, you can also put in the
Yes,
masking sound.
yes.
Do you have to use that very often?
Oh, yes. That's going to turn out to be a very, very frequent prescription in our
So
in our hands.
they need an aid, they're wearing an aid, it doesn't mask the tinnitus, so you add a masker to the aid.
Right,
And so that they're getting both together.
right. Now, those people do not get as much residual inhibition as people wearing pure maskers.
Normally, though, residual inhibition, if I remember correctly from listening to you talk, that it isn't the rule, and it oftentimes doesn't last too long. But
That's
there
right.
are occasional individuals where it'll last 6 to 12 hours.
Yes.
But that's the exception rather than the rule. Is
Very
that right?
much so, very
Yeah.
much so. May I comment on
Yeah.
that? I think that people who are doing work in this area must be very, very careful to explain to a patient that you are not trying to produce residual inhibition for them, but rather the masking itself must be the relief. That is to say, you may not put a bad sound or a bad condition on a patient in the hopes that you would get residual inhibition. If you do get it, it's a bonus, and it must be viewed that way until we know more about how to produce it.
You told me a story coming down in the car, I believe, about someone my friend up in Spokane, Tom Roulant, ENT man in Spokane, who came down and wasn't all convinced he should even come, and he came. Why don't you tell the story about what happened with his tinnitus? Because I think that's kind of interesting.
I did not realize he was
And
an
if
observer.
Tom's watching this, well, he'll forgive us for identifying that he has tinnitus.
Well, I didn't realize he had it, and after watching us test a patient, he then commented that his tinnitus was best matched by a 7,000 hertz tone, and then revealed that he had it in one ear as a result of a 45 having gone off next to that ear 20 years ago. So he's had unrelenting, unchanging tinnitus for 20 years. At that point, the only maskers that we had that would get up to that frequency were in headsets, huge things. So we put the headsets on him, got Tom to adjust it. He sat there for about 15 minutes while we discussed other things. Next patient came, he took them off, we went back and tested. An hour and a half later, we come back and Tom says, my tinnitus hasn't come back yet. And that was a very long stretch.
Sure.
And it turned out it didn't come back for 12 hours. So with 15 minutes of masking, Tom can be clean for the next 12 hours.
Fascinating. A good example of residual inhibition.
It was a beautiful conversion.
Wish it would happen that way with everyone.
Oh, yes.
John, do you have any concluding remarks or things that you would like to bring up or emphasize before we sign off here?
Yeah, I'd like to say a few things, a little bit about, you talked about how you manage the patient, and I have sort of a simple little thing I do is the evaluation, the examination, and the explanation. Because I think that that is therapeutic probably in 95% of the patients with tinnitus. So I don't want people to get the idea that every patient I see I send for biofeedback or tinnitus masker. Obviously the first thing you want to do, the patient comes in because they've got ringing in their ears, they're concerned about it, but if you do the evaluation and the examination, you check them out thoroughly and find out, yes, there's nothing seriously wrong, you may or may not have a slight hearing loss, and this is what it's from. Many patients will say, fine, I just wanted to make sure there was nothing serious. And it's the 5% of the patients, maybe out of 100% that come in, only 5% will eventually require some extraordinary follow-up to try to get them
I'd
through
like
it.
to re-emphasize this because you know, I remember I talked about a cartoon of the doctor with all of his diplomas, and the person says, you mean all you can do with all this, all you can say is live with it? Well, I think that there is a tendency at times to, when something like this, you're not necessarily enthused about seeing this patient, perhaps, and there is a tendency on some people's parts to say, look, you know, three things. You got a hearing loss, you're going deaf, you may have to use a hearing aid, and you'll have to live with your tinnitus, and don't come back and see me. That's the message that gets across to and that's the patient that then finds themselves going to someone else. And what John has emphasized, and I couldn't agree more from a clinical standpoint, that if you listen to the patient first. The average doctor, patient says, I've got tinnitus. He says, okay, next question. You want to know, what does it sound like? Is it there all the time? What makes it better? What makes it worse? Not because it's going to make a great deal of difference in what you do, but because by doing this, that's the first step in psychotherapy. The patient now knows that you know more about their tinnitus than anyone else has because you have listened. You have asked questions and listened. Then the thorough examination, which doesn't necessarily mean anything more than looking at the ears under a microscope and testing with a tuning fork and a hearing test. We're not talking about the need for a lot of x-rays and ENGs, yes, in a unilateral tinnitus, but in the average case, no. And then a clear-cut explanation that they're not going deaf, that the tinnitus is not progressive, that it will usually get much less or go away in the course of time, and let me see you again in a year.
And please avoid loud sounds.
Yeah, well, avoid loud sounds, maybe. Well, I don't normally tell them that.
Oh, please do. That is essential. I don't care what's
must.
caused the tinnitus. I really don't care.
By loud sounds, what do you mean? Shooting range?
Anything you
Rock
have
and
to,
roll? A
anything you have to
discotheque?
talk over
Yeah.
is too loud for them.
Okay.
And I
But
admonish them.
That's
to
what
avoid
John
it.
was getting, and I just wanted to re-emphasize it, to hear it coming from me too, to take the time to let that patient know you are interested, and that means seeing them again. Now, they may not come back when you get their card in a year, but see them again. Reassure them their hearing's not getting worse. Ask them about their tinnitus, and most of them will say, well, yeah, it's still there, but I don't hardly notice it. I want to thank you, Jack, very much for joining us, coming down from Portland. Actually, Jack and I have been talking about this for the last year, and we were just waiting for the appropriate time. We greatly appreciate it. I want to thank you, Ed and John, for joining us here under these hot lights. We're all sort of anxious to get out of this right now. And as I mentioned earlier, Jack, in a few minutes here, I think after we get you wipe the perspiration off your face and get a cup of coffee, we'll sit down and have you tell us more about tinnitus masking. Thanks very much for being with us.